Good morning. I want to welcome you to the Southern Educational Council of Optometry. We're here this morning to start a process of education that will hopefully lead all of you to greater heights in your own profession. We here at SECO International wish to thank everyone for attending and helping to make this meeting one of the most successful educational events in the eye care industry. We cannot offer this kind of leading-edge education without the support of our valued sponsors. At this time, it is my pleasure to introduce one of our most esteemed supporters, Dr. Richard Klompus of the Vision Care Institute. Please help me welcome him.
Thank you very much. Appreciate it. Welcome, everyone. On behalf of the Vision Care Institute and Johnson & Johnson, I want to thank you for coming today. This is actually a very, very important topic on cultural diversity. What you will find being in practice is that many of the patients who come to see you will often look like you, they will speak like you, they will be very much like you. This presentation is all about feeling more comfortable when your patients are different from yourselves. And after being in practice for many years, you begin to realize that a diverse staff and diverse patient group is very good for building your practice. There are many, many individuals now in the United States that are different. And this presentation will hopefully help you go down the road of educating yourself and becoming simply more comfortable and better for caring for people from different backgrounds. What I'd like to do next is introduce Steve DeValk, who is a director of a very talented group of actors. And they will take you through multiple scenarios of what it's like to have a practice with a diverse culture of patients. Thank you very much.
Thank you, Dr. Klompus. Good morning, everybody. What we're going to do is we're going to start right out this morning using something that we've been working with now for about 20 years called interactive theater. And the way that that's going to work is throughout our time together here this morning, we're going to show you 5 scenes that take place in a place that we call Dr. Cole's optometry office. And all you need to know out there, and we'll get this first scene started in a bit for you, is that over on this side of the stage, we have a waiting area in Dr. Cole's optometry office. Over here, we have an examination room. Our first scene that you're going to see this morning is going to occur over here. Again, this is a fictitious team that we pulled together. You're going to see a lot of people kind of converging on the office as the office has just opened this morning. We need you to do a couple of things for us this morning to help us out. The interactive theater will allow us to bring this issue to life and see how it plays out on a day-to-day basis. All the racial, the ethnic, the religious group messages that can play out on a day-to-day basis. But you can help us out that after you watch this scene, it'll last maybe for about 15 minutes. This first one, we'll let it go that long. Then what I'd like to do is check in with you, and you're going to tell us from where you're sitting, what are some of the cultural faux pas that are playing out in this scene up here? And by cultural faux pas, I simply mean those times, and all of us are capable of doing it, of when we step on somebody's toes because we don't understand what culture they're coming from, or maybe even what culture we're coming from. So be ready to name or just brainstorm real quickly some of the cultural faux pas that happen. And then, more importantly, start to watch this scene and start to consider the consequences on Dr. Cole's practice of these sorts of cultural faux pas playing out as they do, okay? So again, fictitious company, we'll say it's an optometry office in Atlanta, Dr. Cole's office, and we're in the awaiting area. Curtain.
Let's see, I have a cancellation this Thursday at 4. Is that a good time for you? Great, great. Have you seen the doctor before? Uh-huh. And will you be utilizing any insurance for your visit? Sure, I can hold. Hi there. Could you please sign the sign-in sheet and then have a seat in the waiting area? Someone will be with you shortly. Yes, I'm here. There's a $20 copay with your insurance. Mm-hmm. Okay. Either cash or credit card.
Mr. Hashimoto,
please
you can have a seat right this way. All right, I'll let you know when the doctor's ready for you, okay?
Yeah,
are you listening to me, Mr. Hashimoto?
Yeah.
I said I'll let you know when the doctor's ready for you.
Yeah, very good.
I can never tell if he's really listening to me or not. I just don't get it.
Hasn't made eye contact with me once since he walked in here today. Yes, I'm here. Good. All right, I'm glad that works for you. So we'll see you Thursday at 4 now. For any reason you can't make it, please call ahead and give us a time because
No, actually, I'm here with my father.
And who's your father?
Rodriguez, Hector Rodriguez.
All right, let's see who's next. Okay, Hector. Hector?
You know, I'm not finding his file here.
Hun, what time was your appointment?
Actually, I don't think he had one.
Well, you need an appointment.
Papá, usted no tenía, ¿verdad? No. No. We were in the area. We were
Listen,
hoping
we're a
that-
very, very busy practice. Dr. Cole sees people by appointment, okay?
He was in here recently, wasn't he?
Yes, he
What difference
was
does that
about 3 weeks ago.
Yeah, I remember now.
Wait, is he having a problem? Because without an
Well,
appointment,
you know
I'm
what,
afraid
Stella?
that we can't
No,
accommodate.
I think we can squeeze him in because Mr. O'Brien canceled. I mean,
All right, okay. But in the future, hun, you have got to call ahead and make an appointment, okay? Thank you. All right, now, Hector, do you have any insurance? Does he speak English? Hector, I need to see your insurance card.
Señor Rodríguez, ¿qué clase de seguro tiene? Necesitamos ver su tarjeta, por favor.
¿Dónde está la tarjeta?
Yo la tengo aquí, espera un momentito.
Pásenla.
Ay. Mira, espera, un momentito. Ay, no me pongas nerviosa. Mira, sácala. La segunda. No, esta.
Esta, sí, esta.
Mírala.
May I help you?
Yes, I have an appointment with Dr. Coles.
Name?
Malcolm Jenkins.
Okay. I'm not finding your file here, Mr. Jenkins. What time was your appointment?
10 o'clock?
Oh, well, no wonder. It's 10:30.
Yeah, I know. I ran into traffic.
Well, it would have been helpful if you had called.
Sorry about that.
Yeah, well, I'll have to go pull your chart again. I put it away. I thought you were a no-show. You can have a seat, and someone will be with you in a minute. There are some magazines there, so. Stella?
Yeah?
Can you do me a favor? I need to get Mr. Rodriguez ready for Dr. Coles. Can you pull Mr. Jenkins' chart for me?
It's not with the others? Did
He's
you
a
check the
half hour
bottom?
late. I thought he was a no-show. I put it away.
Oh, okay, sure. No problem. I have to get the Stevens chart
Thank
anyway.
you. Señor Rodriguez, come with me, please.
Papá,
Sí, vamos.
sigue, papá.
Gosh, what?
Yes.
Oh, I'm sorry. You are going to have to wait out here.
Oh, well, my father feels uncomfortable
Yeah, I
around
understand.
the doc.
Dr. Coles prefers to see his patients alone. It's a very small space. It'll only be a few minutes. Please
You know
have a
what?
seat. Make
It's
yourself
okay,
comfortable.
Stella. I'll take care of it. It's okay.
All right, whatever. I have to run and get a chart anyway.
Okay. Sorry about that. You know, Stella isn't really close to her family, so she doesn't understand why you and your mom want to go in with your dad.
Yeah, my father really feels uncomfortable around the doctor, so thank you.
Sure, no problem. Just follow me. Sí, síganme, por favor.
Podemos-
Vámonos.
Qué bueno.
Sí, vengan para acá.
Bueno, qué bueno. Ay, cuánto me alegro. Gracias. Ay, qué divino. Qué
Hashimoto.
Okay, Jenkins, Mr. Jenkins. Hello. Have you brought your Medicaid card with you today?
Excuse me?
Could I see your Medicaid card, please?
Do I look like I'm on Medicaid?
I'm sorry. Which insurance carrier do you use?
VSP.
Oh, of course. It says so right here. Has your address changed since your last visit?
No.
All right, fine. Then please have a seat, and someone will be with you shortly.
Stella.
Sam. Hey, I didn't know you were here today.
I am sorry I'm late.
Oh, no problem. Listen, Dr. Coles is running a little bit late anyway, so it's no problem.
Okay.
Could you sign in, please?
Yeah. So how you been?
I can't complain. Can't complain.
No sense. Doesn't do any good anyway, right?
Telling me. So what do you haven't done today?
Annual eye examination. I'm a little late.
It's not a problem. Please have a seat, and the doctor will be with you shortly. Good to see you. Oh, hi. Yes, I wanted to just check on an order. I called it in over an hour ago, and it hasn't arrived yet. Sesame bagel, buttered, toasted lightly, cream cheese, a large coffee, 2 sugars. Right. Okay, I'll be here.
Curtain, We're going to stop that here. I'm going to invite our team back out here of the 9 players that you saw. And at this point, before we move on to one more scene, we'd like to check in with you about what you're seeing here. So it lasted about 10, 15 minutes, but we, of course, have it jam-packed with a lot of cultural faux pas, if you will. So let me check in with the audience. Let's just get a few responses up here just so that we know what you're seeing up here. What were some of the cultural faux pas when people stepped on somebody's foot? Nice and loud for us, and I will repeat what you're saying, please.
Hands on the Asian patient.
Okay, and just for point of reference, we had, because you're going to get to know these folks, you're going to be working with them for the next 2 hours, we had Rosie touch the Asian patient, and we saw him kind of uncomfortable about that. Where else we got a mic? Right here, and then you can pass your mic there when you're done. What was the cultural faux pas?
Well, they were speaking about the Asian patient as if he weren't there, and talking amongst themselves about the patients even though they were within earshot.
And how uncomfortable he was making them feel. He hasn't looked her in the eye, so it was more about their comfort level then, and
As
really he
opposed
kind
to
of became invisible.
Everything that happened with the black gentleman. Every
It's
single
every
thing.
single thing, okay? You'll hear from him. He's going to tell you some of his experience up here, and we've got a microphone here.
Well, I was going to say the same thing. She was all upset about the gentleman being late, but then when the other gentleman walked in late, she was all giggly and gooey.
Yeah. And we also had Malcolm seeing that Sam was being treated in a very different way with some of the same circumstances. Let's go here, and then we'll come down here. Yes, please.
Yes, when the African-American gentleman came into the office, she assumed that he had Medicaid. And when she looked into the chart, he had VSP.
Okay, and you could see the reaction in her face. She walked into that with an assumption, and she was quite surprised with what the real situation was. And a comment here.
Yes, Malcolm was asked to sit down and look at magazines, but there was nothing culturally sensitive or interesting for him to look at.
And that's a little bit more subtle one that plays out in this scene. People don't often see that, but for those of you who missed it, and we all see the same thing up here, but we see it in different ways just because of who we are, he picked up the stack of magazines, went through, rifled through 3 or 4 of them, didn't see anything that appealed to him, so pulled out his own magazine. So again, the message it sends to him as a patient and his, is he welcome in that office? Switch the question a little bit, because some people will say with this stuff, and we've done this topic for a long time, big deal. Those are little things, we still provide great care to our patients. But let's just take a minute before we go on to the next scene. What are some of the consequences you saw up here and potential consequences of these sorts of things playing out in this office on a day-to-day basis? So things you saw as consequences and then potential consequences of this. Let's just name 3 or 4 of them, and we'll move it forward.
I think blaming the patients for things they don't control, so putting them off right away. Your chart's not here, you're late. We don't allow other people to come in the room with the patient.
Yeah, and it amazes me when we do this how many times people want to, and the longer you work with them, and I feel this some ways too, we want to turn to those patients and go, damn, if you could be this, we want to change them, rather than looking at, I've got some accountability here. But it's amazing, they're like, well, why does Malcolm have to act that way? He's making my job uncomfortable. They've got to take some accountability. Other consequences, there were a couple more hands up out here.
One big consequence is you're going to lose most of the patients that were there today because of, the way they were treated, and especially the black gentleman. I mean, I would never go back there if I were him.
And you're going to get to see him, and you're kind of foreshadowing where we're going to go. You're going to see that happen. And these folks don't keep this to themselves. We know that. We're all consumers too. And patients, we go out and talk to people about our experience. So very much could be impacting this practice of Dr. Cole's. And then there was one more here, and then we will move it forward. Please.
Rosie's preferential treatment of the Hispanic people who were walk-ins was, if I was a patient who was a little bit late and having to wait and had walk-ins go in front of me, I think I would have been upset.
Let me do one fun thing here, because we're getting a reaction out of her, and we're not going to work a lot like this way today, but with Rosie, I just want to hear, and then we are going to move it to our next scene. Rosie, you were giving them preferential treatment, the Rodriguez family. What was that about?
It wasn't, I really don't see it that way, but okay, I just thought, I've seen them here before. They come in together, and I understand the whole family unit thing and how it works, so I figured, this is something I know a lot about, being a Latina, so I figured I would help them out. I didn't didn't feel like everyone else, forget you, it's all about them. But, okay, all right.
And I will use that as and we are going to move it forward. I will use that as something to watch through all the next 4 scenes, because all of these folks came in here for appointments. You're going to see those. Something to watch, or a lens to watch the scene through, is the intent, the impact. And some of you are familiar with that language. Her intent, if you believe her, and I do, was a good one. She wanted them to be comfortable. The impact, however, on some people would be, well, somebody's getting preferential treatment here. So intent, impact is a whole nother thing we'll layer onto these scenes. So the next scene that we're going to play out is we call Different Strokes. And it's going to play out here, again, in the waiting area of Dr. Cole's office. And we'll say that it's just a little bit later on in the day. Something for you to frame this scene, do watch that intent, impact stuff, and then the other is, look for some of the assumptions behind people's behaviors and words. So similar to, do you have Medicaid? And the answer came, so what was the assumption behind that? Similarly, watch this scene, because you're going to see people approaching each other with a lot of assumptions about who's in front of them, okay? A little bit later in the day at Dr. Cole's office, curtain.
Oh, Sam, so you all set?
I think so. Just need to pay up and I am out of here.
Okay.
How much do I owe you?
Let's see, your copay contact lenses, that comes to $350, please.
Ay, Stella, you're killing me.
I know. It seems like a lot, but look at it this way. You're getting an annual supply of contact lenses, which will last you till your next appointment next year, your next exam.
No, you're right. Nothing I can do about it anyway. I can't live without my contact lenses. I'm blind as a bat without them. Okay. I guess I'll just have to eat bologna sandwiches for a while.
Oh, I feel your pain.
I kid. But seriously, and I know I'm dating myself when I say this, but I remember the days that you could get a loaf of bread for 25 cents.
You're kidding.
Yes,
That's not true, really?
No, it's true. Thank you.
All right.
Thank you. Okay.
Thank you very much.
You be good now.
All right, take care, Sam. Be well. Hi there, how may we help you?
Hi, the doctor gave me a prescription for contacts and glasses.
Okay, all right, hon. Follow me right over here. I see here that you want tinted lenses. Have a seat. Let's try some on over here. We have light blue, amber, and green.
I was thinking about brown or hazel.
Oh, I'm sorry, we don't carry those colors. How about the green? I think those would be nice on you.
I have some friends that went over to Dr. Minty's office and got some really cool chestnut brown lenses. And I think I'll go over there.
Oh, okay. Sorry about that. Shall we look at some frames now? Actually, Rosie, would you mind helping Mr. Jenkins with some frames? I promised Dr. Coles I'd rework his afternoon schedule.
Not a problem.
Okay, Rosie's going to help you.
Thank you.
Okay, so do you see anything you like here? Let me help you, please.
Where do you keep your designer frames, your larger frames? Those don't fit my nose.
Okay. How about these? I think these would look good on you.
No, not my style.
Okay. All right. These.
Too nerdy. Do you have anything with a little bit more stylish?
Stylish?
Yeah, something with a flair.
You mean like this?
Oh, no, it's too girly. Not that.
All right. Try these. Oh, those look good on you. Those are good. Look.
Yeah, but they're too tight on the bridge.
What do you mean?
They're too tight. They pinch my nose. But can I see them in a larger size?
No, they're one size fits all.
No, they're not.
Excuse me?
They don't fit me, so obviously they don't fit all.
Well, we can adjust them so they fit your face. We can adjust them just like so, like just here, like this.
Now, do you have any with adjustable nose pads, like these Prada frames? Now, I bought them from my doctor in D.C. last year before I moved to Atlanta.
Wow, those are really nice frames. You must have paid a fortune for them.
Well, as an attorney, it's
An
important.
attorney? Oh, I didn't know that.
Freeze! Why is she so surprised? Now, actually, this whole experience is getting very frustrating for me. And between you and me, embarrassing. When I arrived today, they thought I was on Medicaid, and I am not. Yeah, I was late, but that receptionist was not as harsh with the other guy who was late as she was with me. And now I'm having a hell of a time getting what I want. Like I said, very frustrating. But hey, let's give them another chance.
Oh, my brother-in-law is studying law at Penn State.
Well, I wish him luck. You know, I bought them because they make me look professional in the courtroom. And looking good is important to me. And I don't mind paying for high-quality, stylish frames. And these cost $500 and worth every penny. People always compliment me on them.
Okay, well, I'm sorry Dr. Coles doesn't carry frames like these, but, you know, there have been a lot of patients coming in asking for designer frames. I'll talk to Dr. Coles and see if we can, I don't know, diversify our selection.
Oh, that's okay. I'll just check around town.
Okay.
I'm sorry we couldn't help you find what you needed today.
That's okay. I'll find what I'm looking for someplace else. What do I owe you?
Okay, no glasses or contacts, just the copay. Just the copay for the office visit, please. And paying by check requires picture ID?
No problem.
Thank you. Oh, you know what? I'm going to require one more ID.
No, Stella, actually, remember Dr. Coles changed that office policy last week? One picture ID is fine.
Okay, your driver's license is fine. Thank you. Sorry about that. All right, just hold on a minute while I make out your receipt.
Not a problem.
And again, I'm sorry we couldn't accommodate your needs today. Hopefully by the time you come back next year for your annual visit, we will have diversified our frames and contact lens inventory.
Thanks. Have a great day.
We're going to stop this one here, and what I'd like to do is we're going to invite Dr. Derek Artis out to put some context around this scene and let you know some of the things that occurred.
I'm Dr. Derek Artis, and it's a delight to be here again this year. Today, we're going to take a look at cultural diversity eye care from an African American perspective. And I'm going to start with one basic premise I'd like everyone to appreciate. One, we're going to assume that we all provide the best clinical care. We go to school to understand how to provide the best clinical care. So we start with that assumption that our practice provides the best clinical care. But when we don't consider the patient's perception of the care we deliver, it impacts the quality of the care we deliver. And so you can see it very clearly with Malcolm. In Malcolm's eyes, he's not received a good experience or good quality care. The doctor may have prescribed the right prescription, may have diagnosed the right disease, but the staff hasn't provided him with a quality experience. And that's really what cultural competent eye care is really all about. Want to look at the African American population in America. Very spread out population all across the country. You'll find African Americans in all pockets, centralized in the center cities and urban areas, but certainly wherever we go in America today, we see African Americans. They represent 13.4% of the U.S. population and growing, about 40 million African Americans in America today. And the CDC, or the Census Bureau, projects that by the year 2050, there will be 61.4 million African Americans. The median age of African Americans today is 31.3 years. That's significant because our patient base, if it's a young patient base, they're going to stay with our practice for years. So the median age of 31.3 years in comparison to 36 for the general population is important. And then economically, the contributions they can make to our practice. African Americans, along with Hispanic Americans and Asian Americans, which will be discussed later, have tremendous buying power, representing almost $500 billion worth of buying power in our communities. So we can't ignore that segment of our population. And then African Americans in general spend money on high quality products. And you noticed in the scene with Malcolm here, Malcolm wanted the best frame. In this practice, Dr. Coles didn't have the Prada frames that he was accustomed to. We also know that in African American and Hispanic American cultures, a high focus on appearance, look, style, and Malcolm depicted that very clearly. He wanted a stylish pair of frames in addition to the high quality frames. I want to share with you some feedback from a study that was done last year. In 2006, the Vision Care Institute did a study of all Americans and asked Americans about our attitudes and perceptions around eye care. And then we looked at, in this study, how African Americans, Hispanic Americans, and Asian Americans' perceptions differed when it came to eye care. And so I want to share with you some of the key findings of that study. First, African Americans hold a more serious and positive attitude about the whole eye care experience, and they seem to recognize that when they go to the eye doctor, that the eye doctor does more than check my vision. They recognize that going to the eye doctor is a complete medical experience. And that's different in some other cultures. In Asian cultures, and you'll hear about it later, they don't perceive the eye care experience as a complete medical experience. So recognizing that when they come into our offices. Secondly, they realize that, again, serious health disorders can be detected during an eye exam. What was ironic about this, though, is they understood that we treated these diseases and we provided full-scale care, but they didn't recognize that there were treatment options available for some common disorders like glaucoma, astigmatism, and presbyopia. The African Americans weren't aware that we have treatment options for those conditions. And that's important for us to communicate in our practices. Mrs. Jones, you have astigmatism. We have contact lenses that can treat astigmatism today. So it's important to make sure we educate the African Americans on the available treatment options. They also displayed a very high level of trust in the eye doctor, a lot of esteem for the eye doctor in the African American community. Again, we touched on it already, but they value high fashion, high quality frames, and they also over-index. And what we mean by that is there's a much higher level of interest in colored contact lenses. Malcolm, again, displayed his interest in colored contacts. We just didn't have the right colors for Malcolm. They're also more likely, African Americans are more likely to purchase multiples. That is, the contact lens wearer will also buy glasses and vice versa. So good opportunity from a practice management perspective to build our practice when we have African American patients. And 30%, ironically, report that they are not providing eye care to their children. So in offices that participate in infancy, very important to educate African Americans that we do treat infants, we do treat children. I want to look quickly at some of the diseases that are more prevalent in African American culture. Certainly, we know that glaucoma is 5 times more prevalent in the African American community. We want to discuss that with our patients when they come in the office, and we always check for glaucoma during a comprehensive eye exam. Interesting enough, not only is it more prevalent, it's also 4 times more devastating, it's 4 times more likely to cause blindness in African Americans. So every African American patient should be checked at least annually for glaucoma, and we want to do a thorough history check for family history of glaucoma and educate them. Higher incidence of cataracts. African Americans are 2 times more likely to have cataracts. And then high incidence of diabetes in the African American community. 13.3% of African Americans over the age of 20 have diabetes. And of course, the sequelae of diabetic retinopathy, cataracts, glaucoma go along with many diabetic patients. Other systemic diseases, certainly heart disease, hypertension that we see in all of America is prevalent in the African American community, but we also see a higher prevalence of systemic lupus and sarcoidosis and sickle cell disease. Finally, I want to talk a little bit about how do we most effectively communicate to our African American patients. Dr. Cole's office talked about how we should not communicate to the African American patients, but let's talk about some of the things that we can do to provide a very positive experience. I read a report, a book called Blink, written by Malcolm Gladwell. Anyone read Blink? Great book if you haven't had a chance to read it. It's written by Malcolm Gladwell. And in his book, Blink, Malcolm looks at patients who sue their doctor or the office for malpractice. And he shows clearly that practices that communicate more effectively to the patient have a much lower incidence of malpractice rates. Even if the doctor prescribed the wrong product or treated the wrong disease, he or she is less likely to be sued when there's strong communication. And so that's why it's so important that we understand how to effectively communicate, whether there's a language barrier or whether there's just a cultural barrier. African Americans want us as doctors and practices to be very explicit about what we want them to do. So we should communicate directly. We need you to do 1, 2, and 3. And they're also very concerned that we listen to them. So certainly we want to take the time to listen and then validate that we're listening to them by saying, Malcolm, I understand that you are going to do this, that, and the other. So validating that we're listening is so important in that community. And it's also important to ask them to repeat back to us what we just told them, to ensure that they understand and that they're going to be compliant with the treatment. Finally, there's some things that we can do in the office that are not verbal. And you saw one vividly displayed here with the magazines. I noticed one of the doctors in the audience pointed that out. That's not verbal, but it communicated to Malcolm that this practice is not interested in me. There's no reading material in this practice that's of interest to me. There's no art or anything in the office that really pertains to me. And that's a nonverbal communication that was missing. So we want to make sure that we're communicating even non-verbally that you're welcome in our practice. We also want to display cultural artwork and magazines that are relevant. And then as we build a practice in the African American community, the best thing we can do is to go out and support the organizations in the community, the churches, the kids clubs. Be visible in that community and show that we're concerned about the community, and you'll see that community will be loyal and support your practice. Finally, as we talked about glaucoma and cataracts and other eye diseases, it's also important that we have information in our practices that discusses diabetes, glaucoma, and eye diseases in the African American community. Just wanted to give you guys a top-line overview of the African American community. Steve DeVolk and his team's going to come back out and finish up the skit here with Malcolm. You'll be able to access, after the conference, backup data, resources, and so forth on the internet. So again, thank you for your time this morning, and I trust that all of you will take some of this information back to your practices and build more culturally competent practices. Thank you.
We are going to move on, and we're going to look at another issue. And as you remember, at the end of our reception scene, Rosie was escorting the Rodriguez family into the examination room. So now for this next scene, we are going to move into Dr. Cole's examination room, which is set over on this side of the stage. And we call this scene All in the Family. And you're going to see the appointment that Hector Rodriguez has with Dr. Coles. So again, back at Dr. Cole's examination room, a little bit later in the day, curtain.
Hector, I was just coming to get you.
Yeah, we had a little mix-up at reception, but it's all taken care of.
Ah, the Rodriguez family again, yes. It seems that you're always together. Well, I guess we need somebody to interpret for Hector then.
Right, I can help with that.
Oh, great. Well, I didn't expect to see you again so soon, Hector. But judging by your chart, it's a good thing you came by. Why don't you have a seat there? Well, from the results of the pretest, it seems that the eye pressure is still quite high. Have you been taking your glaucoma medication, Hector?
Pare. ¿Por qué me llaman Héctor? Como si fuera un niño y me conocieran. ¿Por qué no me llaman señor Rodríguez? Yo nunca lo insultaría de esa manera. No. Yo le llamo por su título, el doctor. ¿Por qué piensa él que puede llamarme por mi nombre de pila. Demando el mismo respeto. Nosotros no somos amigos. Él no me conoce.
My father would like to know why everyone insists on calling him Hector as if he was some child or they knew him personally. He would like to be shown the same respect that he gives to the doctor. He would never call him by his first name, but instead addresses him by his rightful title of doctor, and in return, he would like to be shown the same respect. He would like to be called by his surname, Mr. Rodriguez.
Has he been using the medication to control the pressure in his eye?
Papá, ¿ha usado la medicina?
Sí, sí, por supuesto.
Okay. Exactly as prescribed.
Como el doctor le dijo.
Sí.
Sí, por supuesto. Yo me cercioro de que él lo haga. Yo se la doy a él. Yo me paro ahí y lo velo mientras él se echa la gota. Pero yo siempre estoy ahí segura esperando que él lo haga. Siempre.
Yeah, there's no reason to get upset, okay? These are just routine questions. I'm required to ask them, okay? It is strange, though. I would have expected a change in his eye pressure by now. When was his last physical?
Papá, ¿cuándo fue su última visita al doctor?
Septiembre, noviembre.
No, mi hijo, fue en noviembre.
Noviembre.
November.
November, okay. And nothing's changed in his medical history since then?
No.
¿Qué dijo él?
¿Quiere saber si su salud ha cambiado?
No.
No ha cambiado.
Para nada.
No.
Okay, and he's not taking any other medications, right?
¿Estás tomando otra medicina?
No, nada. Él solamente toma eso, la que él le dio, las vitaminas y el bilberry, que tu primo José le recomendó porque la señora del pueblo se lo recomendó, la curandera.
Eso no es lo que él preguntó. Él no preguntó por la vitamina.
Es verdad,
él preguntó
mi hijo,
por la medicina.
pero como tú
Está
querías
bien,
que él
está
supiera
bien,
todo.
okay.
Pero-
No, my father's not taking any other medications, just vitamins and some bilberry.
Well, now there you have it. Finally, that may be the culprit. Okay, tell Hector that in order for his medication to control his eye pressure and work as it should, he needs to stop taking the bilberry.
Papá, tienes que dejar de tomar el bilberry. Interfiere con la medicina.
And in the future, you should disclose to your doctor any and all supplements that you may be taking, no matter how benign you think they may be. And don't take medications recommended by people other than doctors. Okay, doesn't matter if it's natural, still could counteract with a medication, okay? So let's try this again, all right? You must stop taking the bilberry immediately.
Why is the doctor being so insensitive towards my father? He absolutely prohibits any bilberry and probably any other natural remedies. And between you and me, my father's very unlikely to follow his advice because he knows very well that many of these natural remedies do work. I'll sort all of this out later. Papa, no bilberry.
No bilberry.
No bilberry.
No bilberry. So continue the medication as prescribed.
Siga tomando la medicina como el doctor le dijo.
And come back and see me in 3 weeks.
Tienes que volver en 3 semanas.
3 semanas.
Hopefully then we'll see a change in the eye pressure.
Great. Thank you, doctor. Vámonos.
Gracias, doctor.
You're welcome.
Muchas gracias.
No problem.
Se
Have a
arregló
good
la
day.
cosa y te diste cuenta que el bilberry no.
Pues sí que lo
dices tú,
quiere.
nada de eso,
Claro,
bilberry.
pero toma,
Hay
pero-
que explicar la cosa, ¿no?
Sí, la medicina y el bilberry.
Good morning, everyone. My name is Hector Santiago, and I'm the Dean of Inter-American University of Puerto Rico School of Optometry and President of the Association of Schools and Colleges of Optometry. Census 2000 shows us that the fastest growing population and the largest minority group in the U.S. are Hispanics. No question that by understanding your Hispanic patient better, you can attract, manage, and retain the patient. And by doing so, you can become very successful practitioners and para-optometrics. If you look at the picture here, our histogram, the most outstanding fact about demographics of Hispanics is that between the year 1990 and 2000, the US population increased by 13%, while the Hispanic population increased by 57%. That is 4 times as fast as the general population. As a matter of fact, within 30 to 40 years, 1 of every 4 Americans will be Hispanic. As a group, Hispanics tend to be younger. The median age of Hispanics is 27 years old, while the non-Hispanics whites is about 35 years old. One also significant fact is the tremendous buying power of Hispanics, which they account in the year 2003 to 23% of the buying power of the US population. As a matter of fact, this year it is estimated that the buying power of Hispanics will be $926 billion. 82% of Hispanic households have incomes of $50,000 or more. So this is a population that is increasing very rapidly with a tremendous buying power. Although Hispanics are also very diverse in themselves, there are all common cultural traits and attitudes. One of them is respeto, respect. Respect is deference based on age, gender, and status. Doctors within Hispanic culture are figures of high authority and respeto. But by the same token, the patient expects respeto from the doctor. When you first address your patients, you use the title and family name, not his first name. So you will address Mr. Hector Rodriguez as Mr. Rodriguez, not as Hector. Also, even when they come with their interpreter, you should always talk to the patient. That's very important. And although you may make direct contact with the patient, you should be aware they may not look directly to you because it is considered disrespectful to look directly into the eye of the doctor. So be aware of that fact. Another cultural trait is personalismo. By creating a warm, friendly atmosphere, you develop personalismo in your practice. Feel free to sit close to the patient, lean forward, and use gestures. Familismo is a core value in Hispanic culture. So very often, you'll see family members accompanying the patient because they want to be part of the therapeutic process. They want to know what's happening with their relatives. So as long as you get permission from the patient, feel free to share that information with the family members. What may look as a nuisance may actually be an opportunity for you to develop a very successful practice because those family members may become your patients. And as a group, Hispanics are very loyal to their doctor. Also, you should be cultural sensitive. Be aware that many Hispanics will use herbs and practice curanderismo. Understand and respect the psychological and spiritual side of the complaints. And also, because they rarely will question you, be sure to spend your time to explain at length what the diagnosis and treatment is and what you expect from them. That's very important. A study done a year ago by the Vision Care Institute showed that while the majority of Latinos believe that eye care is important, and while 53% had an eye problem last year, only 43% actually went to see an eye doctor. More worrisome is the fact that 1/3 have not taken their children to an eye doctor. What this means is that once they are into your practice, be sure to educate them about the importance of eye care. Study by Gordon in 1990s showed that the most prevalent refractive error in Latinos is hyperopic astigmatism, while the younger population tends to be more myopic and the elderly population tend to be more hyperopic. But the most important factor about systemic disease of Hispanics is diabetes. 1 of every 4 Mexican Americans and 1 of every 4 Puerto Ricans is diabetic, with the sequela of diabetic retinopathy, glaucoma, and cataracts. Up to 20% of the patients who you see in your office, Latino patients, may have diabetic retinopathy and not know that they have diabetes. Certain types of cancer, like liver cancer and stomach cancer, are twice as common in Hispanics than in the general population. And cervical cancer is 3 times more frequent in Hispanic women. There are two relatively infrequent diseases, but which are still more prevalent in the Hispanics, and they are the pseudoexfoliation syndrome, which can lead to chronic open glaucoma, and the Burkitt-Yamanaki-Harada syndrome, which leads to uveitis and retinal detachment. Finally, macular degeneration is more common in Hispanics below 60 years old. Language can be a barrier. At least one of every 4 Hispanics needs an interpreter. What's the message? If you are a doctor, hire bilingual staff, optometric staff that can speak Spanish language. So better than that, if the doctor can learn enough Spanish to develop proficiency in the examination, that would be great. Always use the full name of the patients. As I mentioned, create a warm, friendly atmosphere, sit close, lean forward, use gestures. In general, Hispanics avoid direct gaze because it's a signal of confrontation when they are members of the same sex, and it may have romantic connotation when they are members of the opposite sex. Hispanics do a lot of more gaze shifting, but that doesn't imply that they're not interested. And lastly, look professional. To Hispanics, the way you look carries the message. Professional attire and look are important. Feel free to use your diploma and your degrees. They are a sign of authority. So, again, thank you for being here today. We hope that you develop your cultural competence skills, you embrace diversity, and by doing that, you become more successful practitioners and optometrics. Thank you again.
If you recollect back to the first scene that we showed you this morning, we have one patient that has not been seen yet, and that is Mr. Hashimoto. So at this point, we're going to invite you back into the examination room at Dr. Cole's office, and we're going to see the appointment with Mr. Hashimoto. Curtain.
Okay, Mr. Hashimoto, so you're here to get your contact lens prescription refilled, correct?
Yeah.
All right, well, let me just take a moment to review your information, make sure nothing's changed. Well, it says here you're having problems seeing at night while driving. How long have you been experiencing this? I mean, has it been getting better or worse? Are you wearing contact lenses or glasses when this happens?
Yes.
Yes, it's getting better, or yes, it's getting worse?
Yes.
Okay. Are you currently taking medications for anything? Are you taking medications for high blood pressure, diabetes, or for your heart?
Freeze. I don't know why I bothered to come here. This glassmaker, he is so stupid. Why he asked me about my heart? Nothing wrong with my heart. I just want him to give me prescriptions so I can get new lenses. If something wrong with my heart, I don't come here. I go to a real doctor. I don't know why I even bother.
And no other drugs, recreational or otherwise, that I should know about, I suppose? What happened to your right eye? Mr. Hashimoto, your eye is red. Did you sustain an injury?
No.
Did you get something in your eye?
Nothing in eye.
How many days has it been red?
Thursday.
Does it itch or burn?
Yes, itchy.
Okay, well, let's have a look, shall we? Okay. Yeah, there's definitely some irritation and redness. Also some discharge as well. So you've said this eye's been bothering you since last Thursday. So it's been bothering you for 6 days? Mr. Hashimoto, your eye has been bothering you for 6 days?
Yeah.
Freeze. Is it just me or what? I'm a doctor, not a mind reader. I mean, is it too much to ask for a patient to actually be involved in his or her own examination? I mean, really, sometimes getting answers from patients is like pulling teeth, which would be fine if I were a dentist, but I'm not. Okay, Mr. Hashimoto, I'm going to take a closer look at your eye with this machine here, okay? Be careful. Excuse me. Okay. Well, looks like we have a classic case of bacterial conjunctivitis. Easily treatable with some antibiotic drops, so I'll write you a prescription. It should clear up in about a week.
It's okay. I go to doctor tomorrow. He give me something for it.
No, Mr. Hashimoto, I am a doctor. I'm going to give you something right now, okay? Do you understand?
Yeah.
Okay. Here's the prescription. Just be sure to take the drops as prescribed and be sure to take the full course.
Yeah.
Okay, avoid rubbing the eye because that'll only inflame it more. Now, conjunctivitis, as you know, is very contagious from one eye to the other and also to other people. So wash your hands after you place the drop in your right eye. And try not to get the tip of the applicator to touch the eye because that'll contaminate the bottle. And try not to touch the left eye to avoid cross-contamination. Also, if you use a towel to wipe your right eye, try not to have it come in contact with your left eye and avoid letting other people use it, okay? And also wash your hands very frequently to avoid secondary infections, okay, Mr. Hashimoto? Do you understand?
Yeah.
Okay. All right. Looks like our time is up, so let's get you on your way.
Now, Dr. Carissa Lee, who will layer some content on and help us take this scene apart.
Good morning, everybody. I want to applaud you first for coming out here, not only to learn about different cultures, but also that you have the foresight to understand that this is really what's behind creating bonds with patients and creating those connections with our patients. And that's what brings them back to our office. That's what keeps them loyal to our practices. You know, we can spend a lot of money on marketing or practice running, practice efficiency, but what it comes down to is those bonds or the connections that will bring the patients back, that keep them loyal, and also create them as advocates, so create referrals for our office. Now, why are Asian patients important? Well, first of all, there's 12.1 million of us out there in the United States, and it's the second fastest growing population. So we're behind Hispanics, but we also have a large community. A lot of people reside in the western area, almost half, and most of these people are in suburban areas, in metropolitan areas, or urban areas to say. We tend to be a little bit more educated, and with that education comes a higher median income. That means that we have a large purchasing power, and we can purchase things that we feel are quality products, so quality services, quality products, things that we hold value. We're willing to pay money for that. Now, even though we may seem like a homogeneous society, Asians as a group, we're actually heterogeneous. We're coming from over 27 different countries in Asia, over 100 different languages coming out there, and we have the most extreme gap between the haves and the have-nots. And to look at why that is, we have to look at why Asians are coming over here. Are they coming over for better education, better quality of life, so they come over here having money to set that up? Or are they coming as refugees? So in the 60s and 70s, we had a large immigrant population from Southeast Asia coming to America to flee the communist government. And a lot of times they came over with really just the shirts on their back. So a really extreme gap there. Another gap is also between those that are assimilated into the US culture and those that are unassimilated. So many of the Chinese and Japanese population that we'll see out there are 4th and 5th generation already. So they've already assimilated into the Western culture versus people that have immigrated relatively recently and may not be familiar with some of our customs, and they may hold their traditions and their values very tightly. Some of these being, for example, holding elders in respect or having a patriarchal society. Also, the gap between generations. Parents that have come over recently and then their kids grow up here. Kids they want to be just like everybody else. They want to be part of mainstream America, and there may be some conflict within the family between those that are assimilated and unassimilated there. Now, in Asia, refractive error is viewed as a flaw. So they're going to want to mask that. They want, they're envious of people that don't have to wear glasses or contact lenses. So we can really create and hone into that niche and not only provide them with contact lenses so they don't have to wear glasses all the time, but create a niche for things like ortho-K or refractive surgery or even one-day contact lenses. You know, in Japan, the one-day contact lens modality is one of the biggest modalities over there. And if our patients are seeing value in it, if they realize, you know, what they're paying for and the quality of what they're paying for, they're willing to pay and shell that money out. Now, going back to the survey done by the Vision Care Institute last year, something that came out of that was that Asian patients, they see the least value in the eye exams, and they're the least satisfied of our patients, which is, you know, it may be a language barrier, but also a culture barrier too, because in Asia, they don't necessarily have preventative medicine. Here, we're kind of used to going in for our annual eye exams or going in for our annual physicals to prevent disease or to keep it in check. There, they really just go if they have a problem. So educating them about why they're there, why annual exams are important. On average, Asian patients come in about every 19 months. So we can slim that time down and have them come in annually every 12 months if we just educate them as to what we're doing and the full scope of our practice. And the other complaint they had is that we don't spend enough time with them. So certainly educating them is going to help in that factor. Now, 61% of us require some sort of eye correction, most of that being myopia, and they're more likely to want to wear full-time correction because they want to see clearly all the time. So certainly that dual purchasing contact lenses and spectacles, we can offer that to our patients, and they're more willing to buy both. As far as eye diseases, they're more likely, or eye complications, more likely to experience dry eyes, allergies also, narrow-angle glaucoma, which is common in the Asian culture, but may seem counterintuitive because most of us are myopes. But when we have to think of the anatomy, and our globes may be a little bit smaller, and creating that smaller anterior chamber leading to narrow-angle glaucoma. Early cataracts we have to watch out for also. Systemic disease is actually the top three are very similar to Western culture. Cancer, stroke, heart disease, those are really prevalent. But in disproportionate amounts, we see hepatitis B, tuberculosis, also liver cancer, COPD also is on there. And when we're communicating with our patients, as a whole, Asians tend to be seen as a shyer culture. So we may be a little intimidated. You know, when we were looking at the scenes with Mr. Hashimoto, he was relatively quiet, man of a very few words, a lot of nodding. And also, we may be intimidated also by direct questions. So, you know, what kind of medications are you taking? What's your health history background? Those may be intimidating questions to us, certainly if we don't know why we're asking them. As we saw in Mr. Hashimoto's case, you know, he says, I'm just going to get my glasses and contacts. I'm not here for a regular exam. So we have to stress the importance of our full scope and what we can do in an optometry practice, not just give out glasses and contact lenses, but also what we're looking for as far as diabetes or high cholesterol, all of these systemic implications that we can actually see during an eye exam. Now, the limited English proficiency certainly will come into play. About 35% over the age of 13 Asians have a limited proficiency in English. So they may bring a translator, or they may be a little bit more independent. And if we can't finish the exam or can't communicate with them properly, maybe we can send them home with a note asking them to bring somebody with them, maybe a family member to help them out. Now, also, as a shyer culture, we want to watch out for some more subtle cues, you know, body language and us looking for them to tell us that they're uncomfortable. So they may not come out right and say, you know, what, hold on, please don't touch me, I'm not comfortable with that. You know, you could see him kind of shrugging Rosie off when she was trying to touch his shoulder. Also, you know, I certainly don't have this being short, but if you're taller, you may want to come down to eye level, and so that you appear less intimidating. So when you're talking to them or asking them questions, instead of towering over these patients, maybe coming down to their level and having eye contact with them. You know, in some Asian cultures, depending on how assimilated or unassimilated or what their cultural background is, they may or may not be comfortable with touching. Also, eye contact, we tend to lower our eyes as a sign of respect. So it's not that we're not paying attention or we don't care about you, it's just that we're showing you respect. And all of these, when you take them as a whole, when you look at where people are coming from and what their backgrounds are, it helps us understand and create that bond and that connection between us and the patients. And creating that connection is what's really going to bring them back to our office. So of course, in this office here, we're seeing a lot of the extremes. And when we go back to our practices, hopefully we can take that back with us to create stronger bonds between our patients and ourselves, and have them not only be loyal to our office, but also advocates. So I really applaud you guys again for being dedicated to all of our patients. Thank you.
We have one more scene for you, and actually you have not seen the patients that are going to be involved in this scene. And I need to let you know that last year this scene was not a part of the program. So up until this point, you've seen scenes that have dealt with racial issues. You've seen scenes that have dealt with ethnicity. At this point, we're going to take a look at religion. And how that sometimes plays out. And I think it's a very important issue. Having done this work for over 20 years, in the last several years, it's become a very, very big issue. Not only in the office here that you're going to see, the fictitious office, but just in a lot of different places that we go, just a very big topic. So we wanted to take a look at that today. So we're going to go back to the examination room for Dr. Coles and curtain.
Aziza, I think we should go.
Jalal, let's just give it 5 more minutes.
But this is ridiculous. They've kept us waiting long enough.
I know, but
Hello, I'm Dr. Coles. I'm sorry to have kept you waiting.
Forgive me if I don't shake your hand.
I think there's been some kind of mistake.
We were waiting for Dr. Kadar.
Yes, my colleague's been detained, so I'm handling your cases in the meantime.
Well, it's just that...
We specifically asked for Dr. Kadar.
I understand, but unfortunately, Dr. Kadar was involved in a little fender bender, so
Nobody told us.
I apologize for that, but as you can understand, it was an unforeseen accident. Someone should have informed you as soon as we were apprised of the situation.
Well, do you have any idea of how long it will be before she arrives?
I don't, but if you want, please feel free to wait until she gets back, or I could have Stella arrange another appointment for you, though I'll be honest, Dr. Kadar is only here on Tuesdays and Fridays, so we may not have an opening for another couple weeks.
Perhaps that's best.
Jalal, I can't wait that long.
Are you sure?
Yes, I need to see someone today. It's getting worse and worse. I can't wait.
All right, then.
Okay, if you don't mind having a seat this way, Miss Mohammed.
Freeze. You see this? This is why we asked to see a female doctor. First a handshake, and now this? How dare he take such liberties with my wife? How dare he touch her in such an intimate and familiar way? In my religion, touching like this between a man and a woman is forbidden. It's reserved only for a husband and wife. I would never disrespect him in such a way. I would never treat his wife with such dishonor.
And Mr. Mohammed, if you'd like, I can get a chair from the reception.
I prefer to stand, thank you.
Okay. Well, I realize that Dr. Kadar is a lot easier on the eyes, but I promise I won't bite. All right, then. Let me just take a moment to look through the chart here.
What is it?
Let's see. When was her last eye exam?
I believe it was about a year or so ago. Isn't that right, Aziza?
No, it was less than that. About 7 months ago, I think.
Okay.
What is it?
And Dr. Kadar fitted her with new prescription glasses at that time, correct?
I believe so, yes.
Yes.
Okay. How long has she been experiencing double vision?
Freeze! Hello, I'm still in the room. I hate when that happens. Some think simply because I am Muslim or because of the way I dress that I don't have a voice or can't speak for myself. Some think the scarf on my head smothers my brain or something. I assure you, I am an intelligent, college-educated woman with quite an extensive vocabulary. I love my religion dearly, but it saddens me that it is so misunderstood. Many believe Muslim men force their women to dress this way, to keep them in line or relegate them to some kind of second-class citizenry. That couldn't be farther from the truth. I choose to dress this way. Do you know why? Well, aside from having a great pride in my faith and believing in the tenet of modesty, many of us dress this way because we don't want men to look at us purely for our beauty or our sexuality. We want them to evaluate us for our intelligence and skill. We cover ourselves so that we may be seen as equals and treated fairly, and not just judged for our physical attributes, but for our minds and personalities as well. However, unfortunately for most of us, the opposite happens, and we become invisible instead. Doctor, I have been experiencing blurriness and double vision for a few months now. At first, it was occasional and not as severe. I attributed it to my glasses because I wasn't used to the new prescription yet, but lately it's grown increasingly worse.
I'm sorry, I just thought that... Have you been experiencing any other symptoms? Sensitivity to light, halos?
Yes, now that you mention it.
Okay, well, from what you've told me and the results of your pretest, I think you have keratoconus.
What is that?
Well, it's a deterioration of the structure of the cornea that causes a bulging of the eye to change from a round shape to a cone shape, decreasing visual acuity, which would explain why you're experiencing some blurriness and double vision.
What causes it?
Well, the cause is unknown, but early studies suggest an allergy or an imbalance of enzymes may play a part.
Is it treatable?
In most cases, it's easily treatable by a contact lens, but I'd like to perform a topography test just to confirm my diagnosis. If you don't mind waiting here, I just want to make sure that one of our examination rooms is available.
Sure.
Yes, of course.
Okay. If you'll excuse me, I'll be right back.
And at this point, I'd like to invite Dr. Ahmad up to the stage. And here again, I need to thank her because she helped us a great deal in putting this scene together and bringing the issues to life. So, Dr. Ahmad?
Good morning, everybody. That was a wonderful scene. There are so many implications to what is happening culturally that we really, really need to get some cultural competency and figure out where we need to be. I mean, it has amazing implications to our practices. Look at the demographics. We have 6 million Muslims nationwide. I had different studies. Some said it could be as high as 7.5 million. I kind of chose the middle ground. 70% of them are going to be born overseas. 30% are going to be US born. The largest populations in the US when it comes to Muslim Americans are going to be in California, New York, Illinois, New Jersey, and Texas. So if you're in from those states, keep that in mind. That 6 million translates to about 1.5 to 2.2% of the American population. And those numbers are increasing on a daily basis. By the year 2010, Muslims are going to be the second largest religious group in the US, second only to Christianity. So we need to become aware. And interestingly enough, you saw Dr. Santiago talking about the fact that the Hispanic community is growing very, very quickly, very largely. Well, the Muslim Hispanic community is the largest growing community that we have at this time in the US. Economic implications. Here, when I was trying to figure out and research some of these statistics, even I was really surprised by some of these numbers. 62% of American Muslims have a 4-year advanced degree, regardless of where they were born, compared to about 27% for Americans. The most surprising statistic is the next one. 48% of Muslim women hold a 4-year bachelor's degree or higher. Don't discount them. They're intelligent. They may be dressing differently, but they know what they want. 50% of these people are in white-collar occupations: engineers, teachers, dentists, professors. As we have heard over and over with many studies, the higher your education level, the higher your income level. What implication does that have? If you, again, assume just because of a cultural bias or a religious bias that they're not going to be able to afford a year's supply of contact lenses or better contact lenses or 2 pairs of glasses, you're actually going to lose a whole lot of money. When I was asked to do this, I thought this was going to be really easy. I'm American and I'm Muslim. What else do I need to do? And the more I started looking at it, the more difficult it actually became because of the fact that you have to differentiate religion from culture. Islam is a worldwide religion. So every culture that we've already heard about plays a part in the religion. The religion overlays that culture. So a lot of times, some of the attitudes that you may find are going to be cultural, and sometimes they may be religious. We have to differentiate between an American-born Muslim versus an immigrant. An American-born Muslim is going to have attitudes similar to yours and mine. They're going to understand the importance of eye care because that's what we were educated in, going to the dentist, having annual physicals. We all understand that. Those are the patients that you can say, hey, did you watch Grey's Anatomy last night? Or, what's happening with the Anna Nicole thing? And they're going to know it. Whereas with your immigrant population, you might not want to do that because they may look at you and go, what are you talking about? Since 9/11, we've become aware of this as a major issue. There was a survey done that asked Muslim Americans, this was done by CARE, which is the Council of American Islamic Relations, that do Muslims feel like they've ever been discriminated against? And sadly, in this time, in this nation, 43% said yes. On the other hand, 40% said, you know what, since 9/11, I've actually had more noteworthy, more kind treatment. And so what we're finding is that the sentiment, the overall sentiment, actually swings between the fear of prejudice and the hope of inclusion. Muslims here want to be included. We are American. 77% of Muslims agree to the question that Muslims worship the same God as Christians and Jews. And only a third of American non-Muslims agreed with that same statement. And I think the disparity is simply because that Christianity and Judaism is part of the Muslim religious narrative, but it doesn't work vice versa. So when you talk to a Muslim and you ask them about Adam and Eve, or you ask them about Noah and Moses and Jesus, you know what? They're going to be probably as aware as you are of a lot of those stories because that is part of our narrative. Now, awareness about eye care. I already talked about the American-born Muslims. Let's talk about the immigrant Muslims. Optometry doesn't exist in most Muslim countries. And overall, those patients who come in aren't necessarily going to see the value of the eye exam. And when they come in, they're not coming in for their annual. They're coming in because they've got some problems. Whether serious, whether it's just blurry vision, they usually aren't just going to walk in and say, I'm here for my contact lenses. They don't really know that you're going to be able to diagnose other health issues through an eye exam. So when I have a patient and I say, by the way, I see some bleeding inside in the back of your eye, and I've asked some medical history and said, there's a possibility you have diabetes, you're going to get a blank stare. They're going to kind of go, huh? How did you figure that out by looking at my eyes? The point there, education. Educate our patients on the full scope of what we can do. When you are dealing with those immigrant populations, as you already heard, that generally eyeglasses are not considered a good thing. They're considered in a negative manner. And yet, ironically, when you try to convince them that contact lenses might be a good option, a lot of them don't think contacts are safe. And then further ironically, if you do convince them that contacts are okay, they don't take the risks of contact lenses seriously. So again, educate, be careful about how you explain these choices to your patient, and just be sensitive to what their cultural norms are. For example, they may say to you, well, what can I do to make my vision better? Don't be surprised about that. When we're looking at, actually before I do that, as I was doing the study, I thought it was very interesting because a lot of times I hear comments about the lack of education or the lack of development in Islam or Muslims as general. And as I was doing this study, what I found was that we couldn't be more wrong. A lot of that information has been lost through times and wars, but this is a manuscript that I found that dates from the 1200s current era. And it's the Eye according to Hunayn ibn Ishaq, and it is very accurate for that time. Muslims, not Greeks, were the ones to describe pannus and glaucoma. Muslims were the first to use the words retina and cataracts. And while in medieval times we were still looking at bleeding as an option for somebody who had a high fever, there were hospitals in all major Muslim cities. All right, let's talk about refractive error. You're going to get a higher prevalence of astigmatism to a higher degree. You're also going to get a lot of myopia. Ocular systemic diseases, this was difficult because, again, I'm spanning the globe, but if I come down to generalizations, the commonly seen things are going to be cataracts, diabetic retinopathy, glaucoma, amblyopia, and increasing rates of fusarium as well as histoplasmosis. The interesting thing about the fusarium, especially in view of what happened last year, is that a lot of the fusarium that is being seen now internationally are resistant strains, and that may become problematic to us in the future. High rates of diabetes, heart disease, stroke, hypertension, high cholesterol. Again, similar to what we see in the American population, but there's also a very, very high incident of joint problems as well as osteoporosis. Communication, verbal, nonverbal. Yeah, I really just want to break it down to a few basics because this is such a complicated topic. A lot of times when you're dealing with an immigrant Muslim, the father or the husband may try to speak for the patient. That's not religious. That's strictly cultural. If they come from a patriarchal society, that's what they've always been used to. The exception is what we saw here with Aziza. And I had not realized this because obviously I don't wear the hijab or the head covering, but the more I was talking to colleagues and friends, the more I was hearing it, that they sometimes feel like they're invisible, especially to healthcare professionals, especially when their husband does come in the room with them, and the husband is in the room with them just to make them more comfortable. He wasn't trying to talk to her, he was being a regular protective husband because his wife has a problem. And so let's all be aware of that. In terms of, let's talk to the patient. Who is our patient? On the other hand, if they cannot communicate and they're using the husband as a translator, that's fine, of course. If language is an issue, keep your explanations simple. Talking louder doesn't work. Doesn't help. In other words, keep your same tone, but just keep your explanations a lot more simple. You're not automatically going to have these patients ask you questions. You might need to actually encourage the patient, say to the patient, you know what, talk to me, tell me, do you have more questions? Always remember to ask that one question. Do you have any other questions or concerns? That will open up a complete dialogue most of the time. But interestingly, depending on the culture, you may have patients repeatedly asking questions and excessively asking questions. And again, you've got to deal with that. Part of what we're supposed to do is answer questions. But don't be surprised if you do see some of that. One of the other things that we found here was that when it comes to Muslim Americans, regardless of where they're born, they do tend to be more comfortable with a practitioner of their own sex. So it was interesting as I was preparing this, my technician looked at me and she said, oh, now I understand. A lot of the Muslim patients that come in here, the female patients ask for you. I have an associate doctor who is a male, and the husbands all go to him or request him. And she hadn't quite understood. So again, don't be surprised if a patient is obviously a Muslim patient and you have multiple doctors in the practice, give them the option. Let them know. Nonverbal communication, and we saw some of that. You know, minimal physical contact with members of the opposite sex. You already saw that. If you're a female practitioner and you shake hands with a female Muslim, no big deal. But if you're a male practitioner, unless she offers to shake your hand first, don't do it because it's just going to become a little bit uncomfortable. The thing to keep in mind is, even in this time, shaking hands is not the major way that the rest of the world greets each other. It's relatively a modern form of greeting, and it's really more European and American than it is for the rest of the world. You're not going to have too much eye contact for the same two reasons you just heard. One is that respect, a form of respect, and number two is the romantic issue between members of the opposite sex. So that doesn't mean that they're not paying attention. It just means that they're holding to their own traditions. If they appear defensive or reserved, keep one thing in mind. We are very, very, very aware at this point of the stereotypes and the potential biases that are out there. And that's our protection sometimes. And it's incumbent on us in the office to overcome that stereotype, overcome that bias, and overcome the patient's reserve and let them know, no, you know what, we accept you. The patients may also have some kind of their own stereotype about American doctors, and that American doctors may not be very, very comfortable with them. To put this all together then, well, what is the implication in our offices? Remember that a lot of these populations have relatively high incomes, and if you mistreat a patient or you are not culturally competent and you make some of these faux pas, well, we all talk about high-speed internet as a great way of disseminating information. Tell you what, it has nothing on an ethnic telegraphing network. They will have the information out to everybody in other cities too within less than 12 hours. So be careful. Not only will you lose the patients that may have been in your office, you may lose that whole ethnic population. As a nation, we're becoming more and more culturally diverse day by day by day. And if we want to be competitive and if we want to be successful, we have to have some cultural competency. Thank you.
What I would like to do is invite our esteemed panel of doctors to come up on stage. We have a few minutes where we can do a question and answer period. I will tell you, sitting in the audience and watching the actors do their excellent work, the hair begins to stand up on the back of your neck. You begin to squirm a little bit because what you see on stage makes you feel uncomfortable. It's really designed to do that. It's designed to help you think about different cultures, how we interact, and how we can all perhaps do a better job by providing better eye care. So, our speakers, why don't you come on up? Dr. Santiago, Dr. Lee, Dr. Ahmad, and Dr. Artis. Are there any questions from the audience that we can answer? We have 4 real experts here.
I have a couple questions for you. Number one, you said that if there's a translator that comes into the room with the patient, you would address the translator with your eye contact?
Sorry, no. Verbally, you would address the translator. Visually, you would be looking at the patient.
You also said to make your waiting room a little more cultural friendly. I don't know exactly what type of magazines that you may get, or
You're addressing that to me? Yeah. Well, certainly I can speak for the African American community. Magazines like Ebony or Black Enterprise, or certainly Oprah is not necessarily an ethnic magazine, but still it makes them feel more welcome.
Okay. And also, I know when I go to say someone's name, I don't know sometimes how to pronounce it. So it might be easier for me just to address the person by their first name versus trying to say the whole name. So what would you do in that situation?
I would say ask the patient. He will be very comfortable to answer you, and the fact that you care about doing it right means a lot to the patient.
Yeah, I want to agree with that. You know, having a really tough first name with a lot of letters that you don't pronounce, you know, I think that just asking them, and we come across this too, when you run into patients and you may be seeing them for the first time, you may not know how to pronounce their name. I think if they have a tough first or last name, they're used to that. I mean, I'm used to people mispronouncing my name all the time. But when somebody actually takes the time to say, you know, I'm sorry, I don't know how to pronounce your name, how do you say it? Then that really shows that you're caring about them, and really, you know, that I think that connection is made between you and the patients.
All right, thank you.
Let me add one other thing to that, you know, particularly with Hispanic patients, because my Spanish is not so good either, Dr. Santiago. Oftentimes I will say, you know, Richard, forgive me, but my Spanish is not so good.
Ricardo.
Rich Ricardo, exactly. You know, I may start the dialogue when that patient comes in with Ricardo, you know, forgive me, my Spanish is not so good. Can you work with me? And so then it kind of takes the pressure off of the patient for feeling like I'm not good enough. You know, so sometimes if you're not really proficient in Spanish, starting that dialogue with a Hispanic patient like that can ease the stress for the patient.
And although an issue has been made about how you are to address a Hispanic patient, remember this is mostly for the first encounters and the elderly. Once you become the doctor of that patient, you can feel comfortable with using his first name, but not before that, okay? So he or she would appreciate a warm, friendly atmosphere. Asking him about himself and the family is all right. Somebody mentioned HIPAA, which is true a concern. But just ask the patient, you feel okay about sharing this information? Of course. That's why they're there, because they want to share the information. They want to be part of the therapeutic process, help his relative to get better. So
I was wondering if the panel could address some of the changing demographics with doctors. A lot of the doctors are female now, and a lot of the ethnic cultures are more accustomed to seeing particularly white male practitioners. And what are some things that women practitioners could do to make patients more comfortable?
I can address the Muslim American population. It's actually very easy. They prefer to see a woman. And so that's really not a difficult issue. In fact, as I said before, my office, a lot of times the couple will separate on which doctor that they see. And a lot of times they will then tell their friends and say, by the way, there is a woman eye doctor at that center who I was very comfortable with. I received a great exam. Remember, you have to do all of the other stuff too. And once that patient gets that information out, you're going to start seeing more and more of those patients.
I think also on that note too, a lot of patients, I think if you can make patients aware, like what you were talking about, if you can make patients aware that there's more than one doctor in their office, if you have multiple doctors there, some patients actually prefer, I'm the only female doctor in our office, and a lot of the kids prefer to see a female, or the parents want their kids to see a female doctor just because they feel a little bit more comfortable, maybe on their first visit. I don't appear as intimidating. And also just to give them that opportunity to have the choice. I think that's the biggest thing.
What if the patient is male and the doctor's female and there are no other options?
When we're really coming down to the religion, there's preferences and then there's need. If there's only a female practitioner and a male patient, you keep casual touch to a minimum, but necessary touch is absolutely fine. One of the things I would recommend is let them know ahead of time what you're about to do. For example, if you've got them behind the slit lamp, I'm about to touch your lower lid, I'm about to touch your upper lid. But absolutely, you will find a lot of, just let's get away from the eyes, you will find a lot of female practitioners in other practices who will have to do a full body exam, and if it's a necessary thing, that's absolutely fine.
Is this class is going to be available on a DVD or tape that you can buy? I would like for all of my coworkers at the office where I work can see this class, because and sometimes at the office where I work, this happens a lot. And it not only makes me upset, sometimes it makes me sad. And then I go home stressed, because I think that it is somehow sad, unfortunately, that not a lot of people is educated in all different cultures. In one instance, when we have Muslims come in, Hispanics, Puerto Ricans, or any other Central Americans, and some of my coworkers has just said Mexicans, and it makes it really uncomfortable instead of just calling, like you say, Hispanics, so American Hispanics, like.
That's a great question that you ask, and the reason that we are performing today's presentation, it's really an encore presentation, including Muslim Americans, due to Dr. Artis's wonderful work from last year. But as being part of the Vision Care Institute, our goal is to provide this as part of a DVD that will be made available at no charge for your staff, your offices, and we'll have that ready probably within the next 2 or 3 months. But the goal will be to help educate as many doctors as we can as a service from the Vision Care Institute and Johnson & Johnson. We have a very large emphasis placed on diversity, not only from doctor to patient, but also a wonderful diversity in the workforce. When you have different diversity of employees, you have a wonderful set of ideas that they bring both to the practice and to companies. And so we stress that in a big way. So I appreciate the question. Yes, it will be available as a DVD in the near future.
Thank you. And I have to say another thing, if you let me. The doctors, I have 4 doctors in the office, and they all do a good job with different, cultures. But in the beginning, the patient goes through probably a bad, experience. They have a good experience with the doctor, but at the end, they have a bad experience at the checkout. And usually patients probably remember the ending part of their experience at the doctor's visit.
Yeah, it's often important, after being in practice for many years, that your staff is just as important, if not more so, than the doctor, because they often spend more time with the patient. So very, very critical and very important. Thank you. Be well.